Hello, good afternoon. I am Dr. Rajasekkhar. Today's webinar is about scaphoid fractures, one of the important bone in the wrist. Of all the bones in the wrist, other than lunate, scaphoid has a very significant role in the trauma because it's always associated with some complications. Fractures of these fractures of scaphoid are always associated with complications if not treated properly or not diagnosed timely. So what is a scaphoid bone? Actually, it is a small bone in the wrist present at the base of the thumb. It connects between capitate, lunate, and then trapezoid and trapezium. So these are the five bones which articulate in between themselves and then form it articulates with the radius. Why is scaphoid fracture important? Because often it is missed at the first presentation because it is not always seen on the X-ray. Fracture is not visible on the X-ray. Regular X-ray positioning cannot diagnose a break in the scaphoid. You need to take special views. Fracture visible only after 6 weeks from the index trauma. Because by the time the fracture is visible on X-ray, in most of the cases, the fracture also starts healing. So if you have not treated it and missed the bus, you will land up in soup. Patient might land up in complications. Anatomy of scaphoid. So this is here it is written 1, 2, 3, 4 is the scaphoid bone. It is very small. It has a boat-like shape, which is reflected in its name from Greek, scaphos, meaning boat. So it actually, as I already told you, this brown color bone is the scaphoid. Pink one is trapezoid, and this dark gray color is trapezium, and then this blue color is capitate, and light blue color is lunate. So it articulates with scapholunate, scaphocapitate, scaphotrapezium, and scaphotrapezoid. With this, it will support index finger and also the thumb. So it is very important bone in the proximal row of the corpus, which provides stability, and also one of the bones which forms articulates with the radius, second largest articulating surface after lunate. Of all these bones, only two bones articulate with the radius. One is scaphoid, the other one is lunate. So why scaphoid fractures are very complicated? Because it all amounts to the blood supply. So anatomy of scaphoid blood supply is very less. It has only retrograde flow, and it comes from the radial branch. It comes from the distal pole to the proximal pole. There is another blood vessel which also gives in the radial at the radial articulation. But after any injury to the scaphoid, that gets disrupted and the blood supply is lost to the proximal pole. So proximal pole becomes avascular. So whenever there is a fracture in the waist or in the proximal pole, the proximal pole did not get any blood supply, and chances of developing avascular necrosis are very high. So mechanism of injury, how do you fracture your scaphoid? One is the usual mechanism is fall on the outstretched hand, applying an axial load to an extended and pronated wrist in ulnar deviation. Occasionally, stress fractures are also seen in sportsmen like gymnasts and in athletes like shot putters athletes. So when it comes to the classification is mainly based on the complication. So when you divide it, the proximal pole number one is proximal pole, that is the most avascular part, and number two is waist. So when it comes to the fractures of the scaphoid, waist fractures are the commonest fractures, that is 65%. Proximal pole fractures account to the 25%, and distal pole only 10%. So the most uncomplicated fracture is having less percentage of incidence, and the highest complication fracture is having 25% of the incidence. So even if the waist fracture, if not treated properly, they also cause complication like AVN of the proximal pole. How do you clinically diagnose scaphoid fracture? So here we are showing one structure called snuff box. We used to inhale this tobacco powder. keeping in that place. Many used to, our old timers maybe, I don't see anybody these days sniffing from that anatomic snuff box in the thumb area at the base of the thumb, where tobacco powder is placed and it is sniffed with your nose. So that is called snuff box. Any pain at this site should warrant a or suspicion of scaphoid fracture, and it should not be neglected. Saying possible at all pain in the anatomics of snuff box. So scaphoid fracture diagnosis comes to X-rays, wrist AP lateral view, and also scaphoid view, a special view. Only in this special view you see the fracture. In the regular X-rays, you don't see this fracture properly because it is covered or masked by the overlapping of the carpal bones. So even in X-rays also, the fracture is not seen always. You might miss it, but once there is a tenderness in the anatomic snuff box, you have to always suspect a scaphoid fracture and advise the patient to go for at least casting. So CT scan plays a vital role in diagnosing scaphoid fractures. It gives an idea about the comminution, displacement, and also the location of the injury. Sometimes there will be a vertical shear fractures which are not seen on X-ray, but you can see them on CT scan. So here is the CT scan images where they are showing very thin line, and in that small bone it is shown where there is a fracture, waist fracture. MRI is not of much use in useful in acute scaphoid trauma because you might always miss the breach in the cortex because of hyperintensity surrounding. There will be always a bleed in the surrounding soft tissue in the capsule which might overlap the cortical margins, and then you might miss the fracture. So MRI is not at all useful, but it is useful in diagnosing the ligamentous injuries, but it is not much helpful in diagnosing fracture. But only idea it gives is that when there is an hyperintensity in the scaphoid, you can suspect some injury is there, but you cannot say confidently that there is a fracture. As you see in this CT scan, there is a fracture line is clearly visible, but here you don't see a fracture line clearly, and but there is always this white that is called hyperintensity. So you can only suspect a fracture. In this, there is a line is visible, but it is not going through the bone completely, so that you cannot see whether it is a complete fracture or incomplete fracture. So here in this MRI, these ligaments looks, scapholunate ligament looks intact. So bone scan, other than this, not widely used in fractures diagnosis, but in scaphoid fracture, bone scan is indicated when there is a wrist injury with clinical signs like anatomic snuff box tenderness, suggesting a scaphoid fracture. When the initial plain radiographs are negative or inconclusive, or when there is an ongoing pain despite negative serial X-rays. So when a patient is having pain despite of negative X-rays, you can suggest a bone scan. But sensitivity, it can only suggest that there is some injury in that like MRI, but it cannot show you that whether there is a fracture or not, but you can also see whether there is an AVN or not. So its sensitivity is more when you suggest this test in within 3 to 4 days after the injury, and fracture may take 2 to 6 weeks to show up on the standard X-ray. So bone scan is more sensitive than X-rays for detecting fractures. So confirmation after negative X-rays, it is important to do a bone scan. Identifying high risk fracture, positive scan can increase uptake, confirms a fracture. So so how to manage a fracture, scaphoid fracture? Management mainly depends on whether you are able to find a fracture line or not able to find a fracture line. Suppose you had a CT scan, sometimes you might miss a fracture, might not be shown on clearly on X-ray or CT scan, or MRI might give only there is an uptake, or even bone scan. So there is no conformity on X-ray. So in that cases, you have to always protect the limb by applying a cast for 6 weeks, and you have to take serial x-rays every week so that till the fracture is visible. If there is no fracture visible on sixth week x-ray, then you can remove the cast. But if there is a fracture visible on x-ray at 6 weeks, you have to continue the cast for 3 months. So when you operate a fracture, indications for scaphoid fracture are displaced fracture. So when you take an X-ray and if there is a displacement of 1 to 2 mm, you can operate it. Unstable angles, when the intrascaphoid angle is more than 35 degrees or radial unit angle is more than 15 degrees. And also proximal pole fractures require surgery. Instability, when there is an increased gap between the scaphoid and lunate bone, where it is suggesting that there is a ligamentous injury. These fractures are very unstable, so you need to operate scaphoid bone fixation and also reconstruct the scapholunate ligament. And also in some cases you suggest surgery because suppose a patient has come to you who is a software engineer or some desktop worker who needs to operate, who needs to use his computer for day-to-day activities and for job, where he cannot quit the job for 2 months, 3 months till the fracture heals. In those cases also, you can, if they want to return quicker to their job, you can operate that. So unstable angles, when it comes to the unstable angles, of all these unstable angles, radial lunate angle is the most sensitive one. Scapholunate angle and scaphocapitate, lunocapitate angle are not very sensitive. Scapholunate angle is very sensitive. If it is more than 15 degrees, surgery is indicated because the fracture is unstable. So when it comes to the RIF, there are two, three methods of fixing it. One is passing a screw percutaneously into the scaphoid bone, 3.5 mm. It is, if you want to pass one screw, you have to use 3.5 mm screw. If you want to use two screws also you can do, because two screws gives rotational stability also. So in that case, you can use two small screws, that is 2.4 screws. So you can use two, which are placed parallelly. And there is another combination also where one screw is placed, the other is K-wire. Some people place K-wires into that, or there is another way also doing it. There is, you put two K-wires, parallel K-wires into the scaphoid and apply a cast. But the only disadvantage is that always compression is not possible in these K-wires. So compressing the fracture is very important in scaphoid fractures. So you will not get compression when you put K-wire. So you have to see with the fracture is not much displaced, you can put K-wires, which is simple. If you But if you have to compress it, you have to go for either single screw or double screw. In comminuted fractures, you can use a scaphoid plate. A volar plate is available now. Very small, it is a 2.4 system. You can use a very small scaphoid specific plate and fix it with the scaphoid plate. So post-op management, it is cash for 3 months in unstable fractures or where fixation is unstable. And in stable fractures, you can remove the cast and immobilize immediately. Patient is can return back to the table desktop work, writing or typing work. He can return. At the same time, we can also start wrist ROM exercises, finger exercises, and all that. Only contraindication is driving and doing heavy load works. You can only do these writing work till the fracture heals. Either we operate or we don't operate. Fracture will take 3 months for the fracture to heal. So the only advantage in surgery is that after 3 months you are ready to work immediately. But if you put a cast, it will take 3 months. You put the cast. After 3 months, you take the cast out and then start physiotherapy. Physiotherapy might take another 2 to 3 months. So, in conservative treatment, it will take at least 6 to 7 months for you to return to your normal day-to-day activities with full ROM. Sometimes there might be some stiffness also, but in surgery, you are ready for heavy load works after 3 months when the fracture has healed completely. That is the only advantage of doing surgery in scaphoid when it comes to the employees who work on tabletop or desktop employees. Thank you.